that is the key point, right? Is that most people don't think about choice as whether or not they get to pick between X health insurance plan or Y health insurance plan with a certain level of premium or a certain level of deductible. These are words that nobody really understands because they don't make much sense anyway. And they think about choice as what doctor can I see? What services can I get? When and where can I get those things? And unfortunately, for too many Americans, either their choice is restricted because they don't have health insurance at all, or because the health insurance corporation, whom they rely on for health insurance, tells them what doctor they can see, what services they can get, and when they can do it. And so we've, like you said, really flipped this on its head. The other conversation that tends to come up all the time, Micah, is the conversation about cost. And again, I feel like that's a misnomer, right? Because the question is always cost for whom. But we really wanted to connect that to the cost question that real people face every single day. Can you talk about how the way that we took this on in the book is shaped by and informed by your experience with your patients every day?
Yeah, so the way we put it in the book is that we ask, what does Medicare for All do to the kitchen table budget? Not just to the government budget, because that's what.
All right. So let's bring on Micah Johnson and Abdul Sayed, the authors of this book, Medicare for All, a Citizen's Guide. Thank you guys so much for coming on.
Hey, thank you so much for having us.
Thank you. Really excited for the conversation.
Yeah. No, this is a really good book. It's really valuable book. It's really accessible, but rigorous and in sort of going through all of these policy details. So Micah, do you want to kind of start us off where you left off in that clip, talking about the kitchen table budget and why that's the sort of budget that's more relevant to this conversation?
Absolutely. And that's what patients are facing every day. I come at this conversation as a doctor thinking about how my patients are impacted by the costs in the system. And the fact is, we just put such a huge burden on working class and middle class people. Almost 10 million Americans are driven into poverty by medical costs every year. Hundreds of thousands of bankruptcies are caused by medical costs. So that's the kind of budget that I think we need to be thinking about when we're talking about healthcare costs. Because the critical thing is that, yes, on a national level, Medicare for All would cost similar or less than the current system, but it would make an even bigger impact for low-income and middle-income folks, because the current system is financed so regressively with $20,000 insurance premiums, whether you're a millionaire or whether you're a nurse. And with Medicare for All, by financing it progressively, the impact that you would have on people's monthly budgets when they sit down and try to figure out how much money they have left over for everything else would be enormous.
Yeah. So, I mean, thinking back to like the Democratic primaries last year, the argument that you constantly heard from critics of Medicare for All was this thing about the costs and how you're going to pay for it, and of course, I mean, the uninteresting answer to how you're going to pay for it is with taxes, with progressive taxation, right? But do you I really want to spend a minute on why that would be so much better for most people.
Let me jump in here. The crazy thing is that we don't know how we're going to pay for it now, right? 10% of people in our country do not have health insurance because the system is so damn expensive. And so it's crazy to me that we're not asking, how do we pay for the status quo? It's like we got ourselves in this terrible financial bind. There's an obvious approach to fixing it, and we're too busy, right, asking why that's going to be better when it's clearly and obviously better, and we're struggling with what we have right now. So we spend 18% of every dollar spent on our economy in healthcare, right? That for mediocre health outcomes, life expectancy that is 6 years shorter than Japan, where they're the longest lived country in the world, 55th when it comes to infant mortality, and 10% of our population doesn't have health insurance as it stands. And so this system right now is the unaffordable one, right? Medicare for all is the affordable one. It would cost us less because of the elimination of the absurd overheads in our healthcare system. It would establish a government monopsony that would bring prices under control, and it would include every single person in the country. And so the real question is, how can we continue to afford this system where costs are too high and spiraling out of control? And why are we not leaping to establish an approach that would be far cheaper and more effective and far more equitable?
Yeah, so I want to pick up on like 2 or 3 threads of what you just said. So the first one was about so like you said, it's how we're going to pay for what we have now, and that can be true in a couple senses, right? One, and probably the one that's most important, and I think this relates to Micah's point, is how are people who currently don't have insurance going to pay for what we have now? Because clearly they can't, or at least a great many of them can't. I think something like 45% of people who don't have who are uninsured right now, say that that's because of the cost. But then the other half of that is about the costs itself. Like the costs for anybody. So as far as the first half, people, if we're paying for it by progressive taxation, obviously, not only that's fairer, and that allows people who to have it even if they couldn't buy it as a commodity, but also there's the issue of controlling costs, which you talk about in the book, and you say because this is something that I think is a sort of pseudo sophisticated objection you hear a lot to Medicare for all, and people say, there are all kinds of reasons why healthcare is so expensive in America. And, Medicare for all isn't going to just magically fix that if it's still fee for service. But something you guys talk about in the book is that under Medicare for all, the government has a lot more tools to control those costs.
It's exactly right. And I think there's a lot of misunderstanding about why healthcare costs are so much higher. And when we have the wrong diagnosis, we pick the wrong treatment. So it just turns out that healthcare costs, they're not higher because Americans are using more healthcare. Right? We're actually going to the doctor less than in other countries. We're going to the hospital less than in other countries. Our costs are higher because every time we do get care, the prices are so much higher. And that seems like a very simple thing to say. Our costs are higher because the prices are higher, but it's actually profound because it puts out of bounds so many explanations, the sort of pseudoscientific explanations for why costs are higher, because so many explanations lead to the conclusion that, therefore we're getting more healthcare. Like, for instance, if you blame fee for service, really what you're saying is that we're giving people too many services.
Right.
And, we can have debates around the edges for that. And there's a very good debate to be had around that, but it just comes down to the prices. And it's no mystery why, for instance, Medicare today gets prices that are 30% to 50% discount on private insurance. It's negotiating power. Having a big federal program can set the prices, you simply bring the cost down.
Yeah. So, I like your point about the fee for service argument, because this is something like, this is like the premise of the Cadillac tax from the ACA, that the problem is that people are just gonna people love going to the hospital so much, they're gonna do it all the time, unless we financially disincentivize them from doing it, which doesn't actually seem to be that doesn't seem to be the problem. Like like you say, around the edges, okay, right, but for the most part, that doesn't seem to be the problem. Certainly that doesn't seem to be most people's problem.
That's right. I mean, the hard part is that I think sometimes healthcare experts are conditioned to be so myopic about what's possible because they ignore what they think is politically infeasible. And so long as they can ignore what they continue to think is politically infeasible, they will continue to focus on myopic solutions that beat around the bush rather than take on the big issue. And the other part of that is that there is a feedback loop that happens when experts don't talk about the obvious set of solutions. They don't look like solutions. And so part of what we want to do with this book was break that down a little bit, right? We want to kind of take a big gong to the question and say, hey, there's an obvious set of solutions that actually addresses the central core rot in the middle of our healthcare system. And the fact that we've been ignoring that for these technocratic fixes as if they're going to actually solve the fundamental problem where we have a major non-essential industry profiteering at the core of our healthcare system to the exclusion of the poorest people in the country. Right? The idea that these technocratic fixes are going to take on that moral problem is itself absurd, and we have to address that. And look, I think it's really important for us to be thinking about whether or not fee for service is the best model, et cetera, but within the bounds of a system that actually works, rather than assuming that our myopic answers to myopic problems are the grand answer, which they're absolutely not.
Yeah, and I like your moral clarity about that. That about the sort of central obvious problem with the obscenity of treating something that's a important human need that people like have to have. That you will in many circumstances you will literally die if you consume something as private commodity. But also, I have to say, like, one thing that I do like about the book is that it does get into the weeds with what's wrong with a lot of those technocratic fixes, which I think is probably one of the things about it that's most valuable for people, certainly in the audience for this show, who overwhelmingly already have the sort of moral case that yes, of course we should have Medicare for all, but might not know how to counter some of these things or sort of explain what's wrong, with some of these ideas that are brought up by people who say, oh, you don't need Medicare for all. We can just build on the ACA. We can just do some wonky fix to bring down costs, and that'll be fine. And I think it's a really good resource for explaining why why none of that would address all of the problems that are caused by the existence of this like parasitic middleman industry. But I do want to start with the thing that I think cuts closest to like that core moral argument, which is the stuff that you talk about at the very beginning of the book about why, like, even in purely economic terms, even if you think, okay, there are like some things that markets are an efficient way of distributing, that we can have, that it's good, that like it makes sense that like whatever, I don't know, toothpaste, is a market, like a market good is something that that it's that the best way to get people what they want from brands of toothpaste, is to go to the grocery store and make consumer choices. But at the beginning of the book, you guys break down like a bunch of like really straightforward disanalogies, like ways that health insurance and healthcare are just not like toothpaste or other market goods.
Yeah, and it's kind of stepping back. It's, to me, almost more remarkable that so many of us have been trained to think of healthcare like a market good, because it's such of jamming a square peg into a round hole that when you think about it, it's kind of crazy that we thought this could work like any other commodity in the first place. And one of the stories we tell is of a young woman, Lisa Cardillo, who has chest pain, ends up having a heart attack in her mid-30s. And if you think about just every step of the way about, one, what kind of care does she need? Well, that's part of why you go to the doctor. You don't know what kind of care that you need. And then where should you get care? Well, you have to get care quickly, and there's only so many places around. And then you get into the hospital. And then you don't know how much stuff costs because no one tells you how much it costs. And then the insurance company is paying most of it anywhere on the back end. It's not you. So there are so many obvious ways where this breaks down. And then there's also really good research on it. Even if you take kind of the crystallized case, where we cite a study where the closest thing to a commodity in healthcare would be something like MRI of your leg, like an elective MRI of your leg. The quality doesn't change very much. It's relatively abundant. It just turns out that when you do give people that price information and kind of ask them to be consumers of lower limb MRIs, and you give them some skin in the game with the deductible to make them pay for it, people just aren't shopping around for healthcare in the same way that they are for other services. In the study, the average patient would drive by 6 lower priced MRIs before they got to the one that they actually got. And that's in sort of the idealized case of something that might be treated like a market commodity. And then what I see a lot of on the health policy expert side is people think that, okay, if you can just change one part of it, like there's some excitement now around price transparency. So instead of the patient that we tell the story, Lisa, of getting a heart pump while she's in cardiogenic shock in the ICU, if you say, well, we're going to tell her what the price is beforehand, it just turns out that I think that's misguided. There are so many failures that by trying to nibble around the edges, you're not going to make healthcare into toothpaste. You just can't do it.
Yeah, like so and even in those examples, like those are like when you're thinking about whether like individual procedures, could be treated like toothpaste and have that like just market forces could act the way that they're supposed to, when it comes to something like toothpaste. There are all of these, disanalogies, that you don't show up to the hospital the way that you show up to the grocery store knowing what you want to get. You're being told what you want to get. If it's like the old thing about the commercials that end with, ask your doctor, such and such is right for you. It's like, wait a second, am I telling my doctor what's prescribed for me? That seems weird, right? Like, like that seems, is he a doctor or a drug dealer, right? I'm not requesting what I want him to give to me, right? I'm hoping that, he or she or they will tell me, what I actually need. And, it's often happening in emergency decisions where it's very hard to, you're not going to window shop, hospitals, when you need something to happen in the next, hour, to save your life. But even when, and maybe even especially in a different way with health insurance, it's very weird to think of it as something that could work as a market good, because, which is the premise of like, ACA marketplaces that, that we're going to window shop for health insurance. But certainly, and I think the overwhelming majority of normal people are not going to, when they're reading descriptions on a website of health insurance plans, the differences between them are just going to be completely baffling to them, or certainly that's always been my experience.
Ben, let me say a couple things about that. Right, the first is that my wife and I are both doctors, and I'd say I understand health insurance pretty well. And the last time we had to choose between plans, like we full on thought about pulling out an actuarial table to figure out what the probability was as a 36 and a 34-year-old that we were going to have a really catastrophic health issue, and or she was going to get pregnant, which would have been our biggest cost. And so in order for the median person who likely doesn't have the same kind of training or expertise in healthcare to try and differentiate between these various plans that involve different levels of government bureaucracy and different juxtapositions of different costs that you may or may not have to pay at some point in time is kind of absurd. I don't think that's the choice that most people want. Most people want the choice in doctor. And the number one gatekeeper of your choice in doctor is the health insurance industry. The second point is this, Ben, look, if I were to come to you and say, hey, Ben Burgis, I've got 5 MRIs for $500. They're non-transferable. Would you like to buy them? You probably say no, because you don't need MRI, right? But here's the thing. Let's say you went out, decided to play soccer or basketball with some friends. You twisted your knee and felt a pop. And I came back to you. I said, Ben Burgis, you didn't buy those MRIs. I'm selling you one for $5,000. Would you like it? If you had the money, you probably say yes. Why? Because an MRI is critical for you to figure out what's wrong with your knee and getting back to health. The point here is that we don't actually want health care. It's not a consumer good. It's not something anybody just wants. Health care is a means to getting back to what we actually want, which is health after we lose it. And you realize 2 things here. Number one, health care is inelastic in the moment of need. And so it creates these really serious problems of power around when and how you charge people for healthcare if you're trying to make money off of it. The second
is that it creates a major disincentive to preventing you from getting sick in the first place, which is, of course, what everybody wants, because you only make money in the system after people get sick. And so it's critical for folks to understand that and to appreciate that healthcare is not a consumer good. It should not be treated as one. And we have a moral responsibility to answer the public good of healthcare for people if and when they need it. The last point I'll make is this, right? Your body, my body, Micah's body, Natalie's body, who you come on is coming on after, all of our bodies are worth the same, right? We believe that in our society. We believe that it should be a good, that everybody's body should be treated the same way if it gets sick, right? I mean, the adverse of this, it'd be a crazy system if we had a legal code that punished people differently for murder depending upon the net worth of those individuals, right? And what we're getting at here is that there's something inviolable that is existentially important about a body to a human being. But in our healthcare system, we treat your body differently, right? We literally reimburse for the same care differently depending upon how much money you have. That's a crazy thing. And it doesn't meet our moral criterion.
Yeah, I mean, I really like the murder analogy. That you imagine reporting, filing a police report for a serious crime, and having it be officially above board that it would what sort of investigation you got, how seriously it was treated, depended on whether you had the bronze police plan, the platinum one, the gold one, that would be just morally offensive on the face of it, but that's literally how the existing health insurance system works.
That's exactly right. And it is that level of moral failure that's baked into our system that we also conveniently ignore, right? And it's frustrating because people deserve better, and it's been this way for too long in this country, and people are suffering on the back end of it.
Yeah, and I want to get in just a few minutes a little bit more into like the politics of this, and into why we don't have it, why this is such a like hard fight, and what that fight looks like coming up ahead. But first, I did want to get into a couple of the sort of proposed technocratic fixes that people put out there as alternatives to Medicare for all, and what you guys say in your book about why why they don't make sense, or why they at least aren't actually alternative paths to the same goal, because that's what people will say. Look, I want the same thing that you guys want. I want universal care or whatever. We're just arguing about what the best way is to get there. But actually, a lot of these things just don't achieve, like straightforwardly don't and couldn't achieve a lot of the same goods that Medicare for all would. So one of the technocratic fixes that you guys talk about in the book is the idea that what we should really focus on are these kind of fixes that would bring down costs while keeping it while maintaining the existence of the private health insurance industry, while keeping this as a market commodity. So, for example, some policy experts will say, "Oh, we can do things like we can give insurance companies tools to bargain down the price from hospitals." Like making it easier to exclude more expensive hospitals that charge higher prices from insurance networks, or we can make it harder to consolidate hospitals, and so hospital systems, which if they're consolidated, that makes it easier to jack up the price. And I thought that was one of the most interesting things in the book, where you're talking about the reasons why none of this would actually achieve the same goods as Medicare for all. And in fact, these things would make some aspects of the current system even worse, or some of them would.
So here's how I think about that suite of proposals. I think almost everyone in healthcare agrees that current healthcare markets are broken. And I think there is some debate about whether they could be fixed. And I think there are a number of proposals in the category that say, yes, our current healthcare markets don't work, but if we did X, they would work better. And, some of them, in my view, would have some small positive benefit. Like, for instance, the fact that we've allowed our hospital systems to essentially become local monopolies and oligopolies all over the country, where folks just have, in most cases, one or two big hospital systems that buy up all the other hospitals into these giant networks and then jack up prices. So yes, it would probably bring down prices, who knows, but by some number of percentage points, by doing better antitrust against hospitals. And I think there are good political reasons to do that, because concentrated economic power means concentrated political power. Right. And I think that's a problem too. But when you really just step back and you think about the size of our problems, the fact that 30 million people are uninsured, the fact that we have an entirely regressive payment system where the poorest Americans are paying a third of their income for healthcare, you can't just shave one part of healthcare costs by a couple percent and think you're moving forward. And then the point that you're getting at is that there are also ways why making healthcare work more like a market could be bad for patients, like making it easier to exclude hospitals, exclude doctors, exclude drugs from insurance plans. That would make things, in theory, more market-like negotiations, because then the insurance company it's easier for them to say no to the drug company or say no to the hospital. The problem is then you just make plans skimpier and skimpier and skimpier for patients. So I think what this tells me is that we're either making things a little bit better in terms of cost or making things noticeably worse for patients. And I think it would be a mistake to kind of hang our hats on this as the way to go for health reform.
Yeah, and one specific point that you made about the way that it makes it skimpier for patients was that one of the things that's been suggested to like technocratically like fiddle with the system to make it more market-like and bring down costs is making it easier to exclude things from networks. But the second I got to that, I thought, oh my God, that's awful, right? Because one of the if you're a person who has insurance, right? You're not among the millions, who are uninsured, and you have insurance that you can afford to use, which doesn't go without saying, and you don't, you're not being, bankrupted by it, etc. Like one of the worst things about, having, private, usually employer-based, health insurance, is that you have to constantly worry about what's in network and what's not. So you have so for example, if you're in a if you're far from home and you have an emergency medical need, then there's a worry. Is the hospital where I go to going to be a network? And am I going to get a big bill? And even just in the sort of most mundane kind of healthcare needs, like if you just have long-term prescriptions that you have to go see a doctor once every few months purely just to get the prescription refilled. That's it. It's routine. It shouldn't be dramatic. One of the worst things about this system is that every time you change jobs, every time your employer decides to change your insurance, then you have to find a new person who can prescribe this thing for you, who is in network. You have to do a little research to find out who that person is. You have to wait for that initial appointment. You have to wait while you're counting out the pills, and having it be even more limited. What's in network, is the kind of thing that I understand how somebody could get there if all they're thinking about is, okay, what are possible ways to tinker with the system that would have the effect of bringing down costs if this is we basically still have a market system. But if you're thinking about the actual experience of patients, I mean, that's kind of horrifying.
That's right.
Go ahead, Micah.
I say it goes back to the clip you played at the top of the show about choice. And you think about it, who has more choice? Who is more free in their healthcare choices? Is it someone in the employer-based insurance market, or is it someone on Medicare? Where if you believe the political discourse, the person on the private insurance market has all the choice in the world. They can choose Aetna, they can choose Blue Cross, they can choose United. all these beautiful choices. But the whole premise of the private insurance market, one of the things that makes it a market, is that each of these insurance companies decides what's in and what's out, which hospitals are in, which hospitals are out. That's how they negotiate. So any person on those private insurance plans has their choices restricted in very real ways. Whereas on Medicare, they, Medicare Advantage and sort of privatized Medicare aside, someone on Medicare, you might say, oh, well, they don't have any choice in their health insurance. But what they do have is a plan where all doctors and hospitals are in network. And I think in a very straightforward way, people on Medicare have far more healthcare choices and have more freedom in their healthcare. And I think that's one of the ways in which our political conversation gets things backwards. And I think it's no coincidence why that's the case, where it's the insurance companies want you to believe that you have less choice on Medicare, even as they're the ones who are restricting the choice of healthcare that patients can actually get.
Yeah, Abdul, you were going to say?
Yeah, no, I was gonna add, the hard part about most bureaucracies is that they're designed by bureaucrats, and bureaucrats usually make things easier for them and not necessarily easier for users. And so, we've got this broken system, and bureaucrats inside of it are like, oh, here are some things that we could do to theoretically fix the following set of problems, but they miss the entire user experience of the system. And in doing that, right, you end up forgetting the most important part, which is the user at the center. And so healthcare has become more and more complex, harder and harder to use, and more of a challenge for people who are already being chewed up and spit out by the system. I also think Ben, you just came back right in time, man.
Yeah. So sorry, I don't want to make you repeat yourself too much, but you said bureaucrats generally design things to make it easier for them.
Yeah, they design it around themselves and their own experience of the system rather than around the people who use it every day. And the problem is that a lot of times when you decide that you are going to ignore the moral rot at the center of the system, you end up designing more and more fixes that make the thing more and more complex and harder to use for the end user.
Yeah, right. Which, because that's like it's almost like the was it the old lady who swallowed the fly, right? You have you have a fundamentally like broken and system that just isn't going to get what most human beings want out of it, and you introduce a complexity to solve one problem, and you end up with because you've maintained that rot at the core of the system, that complexity that you've introduced to solve one problem is going to lead to others elsewhere. That unfortunately makes a lot of sense.
And then you swallow a horse and die. So